All right, so this week we are focusing on parasitology. It's a very large PowerPoint, so this will take a bit of time to go through it all. I'm just going to jump right into it, and then when we go into class together, we'll of course make sure that we consistently look at pictures. So, all right, so there are 6 divisions to parasites in general. We have protozoa, which is our flagellates, our ciliates, nematodes, roundworms, and so on. So you can see them kind of all listed there. We're definitely going to get to know each of these categories. We are not going to focus on the last 2 or 3, though. Mainly the first 3 is what we're going to spend our time on. All right, some terms that you might hear or see in the textbook when you read. Obligate means that a parasite can only live within a host. Facultative means it can live in or outside of a host. Endo are those that are inside the body, and ecto on the surface. And then the stages. Definitive host is where the parasite lives its adult and sexual stage. Intermediate is where it lives its larval and asexual stage. And of course, anything that's a reservoir is just harboring that parasite for the time being. So we will start first with our amoebas. Amoebas are all single-celled. They move by pseudopods, so that's their form of motility. And they're definitely a fecal-oral type of ingestion to contract these. You're going to find that most of our parasites throughout the whole PowerPoint are going to be fecal-oral. There are some that are not fecal-oral, but that is a lot of it. All right, so out of all the amoebas, Entamoeba histolytica is the biggest pathogen. It is a huge cause of both amoebic dysentery and amoebic liver abscesses. There's a lot of other amoebas that you still need to be aware of and know. Entamoeba hartmanni, Entamoeba coli, and Iotamoeba bushleyi are all 3 going to also be necessary for you to remember. So we are going to start first with the amoebic liver abscess caused by Entamoeba histolytica. So there you can see a liver that's been damaged by that parasite. And so the stages that we are going to look at here are going to be called trophozoite and cyst stage. The trophozoite stage is going to be the mature adult stage of the amoeba, whereas the cyst stage is going to be like the immature, kind of looks like an egg, if you will. It's not an egg, but it's called a cyst. All right, so for Entamoeba histolytica, that's what this one is specifically referring to on this slide. In the trophozoite stage for the Entamoeba histolytica, has very much that amoebic appearance. Kind of when you think of amoeba, you think of like a blob, and that's what the trophozoite stage is going to look like, that little blob. It will have one nucleus, a single nucleus with a small central karyosome. Just an FYI, a karyosome is a clump of chromatin in that nucleus. Just like when you're in hematology, you learned nuclei and how to differentiate, you learned chromatin inside there. Same thing here, we have these concentrated clumps of chromatin that are called karyosomes. So within the Entamoeba histolytica trophozoite stage, I'll have one nucleus with one central karyosome. And then the very key characteristic sign of Entamoeba histolytica is the fact that its endoplasm, or if you want to call it cytoplasm, it's up to you, but its endoplasm can contain ingested erythrocytes. That is very characteristic. It's a big, big thing to remember that Entamoeba histolytica can have these ingested erythrocytes inside the amoeba. So if we take a look here, there are several pictures of Entamoeba histolytica. Like I said, kind of looks like a blob, right? It looks like a basic amoeba when you think of amoeba. So there, in each one has its nucleus with a central karyosome. You'll notice the picture in the bottom really highlights those ingested red cells. So all those dark round clumps inside is the ingested red cells. Again, very, very characteristic for Entamoeba histolytica. It's one of the things that we use to help identify it. All right, as far as the cyst stage goes of Entamoeba histolytica, they're going to be round or spherical cysts. They are going to have 1 to 4 nuclei, and they're going to have chromatoid bodies. So I highlighted or bolded that because I wanted you to remember that's also a key sign of Entamoeba histolytica cysts, is that they have these chromatoid bodies. So those dark, kind of rectangular or oval shaped are the chromatoid bodies. Or if you look in the one in the upper right here, it's not as dark. It didn't stain as, it wasn't using the same stain. That's why it's not as dark as the other 2. But you can definitely still see it there. And then you see one little round ingested red cell. So again, 1 to 4 nuclei. So you can see how these have several, and then those round, or not round, I guess, oval-looking chromatoid bodies. So definitely be aware of Entamoeba histolytica, both the trophozoite and the cyst stage. Here are some drawings. Sometimes drawings are nice, of what they would look like. So of course, the top couple are the trophozoite stage. The bottom are the cyst. And here it is in real life. These are just not stained. They're just black and white pics, but you can see at the top the ingested red cells, and then as it goes to the cyst stage, more the nuclei, and then sometimes you'll see the chromatoid bodies pick up. All right, as far as the overall life cycle, I don't do a lot of testing on this right now. For you guys in micro, you just need to know little details here and there about the different parasites, and then definitely what they look like, the pictures of them, because that is still the number one way to diagnose parasites, is seeing it under the microscope and being able to identify it. So as far as just the general life cycle, just to kind of give you a background here, again, it's a fecal-oral kind of passing. So you're ingesting these cysts, typically on contaminated food or contaminated hands. The cyst is very resistant to the stomach environment, that acidic environment, so it can pass right through into the small intestine, where it basically lives and replicates, and then will move into the large intestine. From there, you just kind of, it does its thing, it does its damage. You got diarrhea happening, that amoebic dysentery. It also can jump into the vein above the large intestine and travel to the liver, and that's how it causes liver abscesses as well. So both the amoebic dysentery and the liver abscess are seen with this. So it's just kind of a picture view of a life cycle. All right, so that was just some background information. Other signs or ways to diagnose it. Of course, we're going to do symptoms, history, have they traveled anywhere? Travel history is huge with parasites, because not all these parasites are found everywhere. There's some that are very specific locations only. Most parasites want really, really warm temperatures. So typically, if you've traveled outside the U.S. to, say, the Bahamas, or to, Costa Rica or something like that, something warmer where maybe there are more parasites down in that area that we wouldn't necessarily see up in the U.S. So history, epidemiology are all keys here as well. And of course, actually seeing the cysts in the stool, or you can even see the trophozoite. Typically, we're seeing the cysts more than the trophs. Entamoeba histolytica, if you want to differentiate this from a bacterial dysentery, we've learned all our bacteria that causes dysentery. The difference between a parasitic and dysentery and a bacillary or bacterial base is, in a bacteria, they're going to have a high fever, a lot of neutrophils responding, whereas in a parasitic, you're not going to see that as much. You're going to see a lower fever, not as many neutrophils responding, because again, neutrophils target more the bacteria. But you'll see a lot of same symptoms: bloody diarrhea, cramping, abdominal pain. All right, so these charts come right out of your textbook. I think these are amazing charts. I love these. So I kind of have these throughout the PowerPoint. What this does is it gives you an overall view of all the amoebas that I'm going to require that we remember. So here on the top row is Entamoeba histolytica. It gives you the characteristic information of the trophozoite stage. And then over here, it gives you the characteristic information of the cyst stage. So just like we went through, trophozoites, it can contain ingested red blood cells, has one nucleus with a small central karyosome. In the cyst, it has 4 nuclei with chromatoidal bars. So just like we mentioned, and that's listed here as well. It does list size. Yes, size is very important in parasites, because size will help differentiate between them if they look really similar. But I am not going to ask you to remember size at this point. We just don't have enough time to get everything down, so don't worry about the size. What I do want to mention before I move on to our next amoeba is the motility on the trophozoite. You'll see that there's a whole column here just for motility. And you'll notice that the only one that has really good motility is Entamoeba histolytica. And that's the one that's the main pathogen out of all of them. So Entamoeba histolytica, really great motility. All the rest are pretty sluggish, slow, non-directional. So just keep that in mind as well. So again, out of this list of amoeba here, we're going to remember Entamoeba histolytica, Entamoeba coli, Entamoeba hartmanni, and then the last one, Iotamoeba bushlii. We're going to just skip Endolimax nana just for the sake of what we have to know. So those are going to be the ones that we go through here, but you can come back and reference this chart. It's great because it puts it all into one snapshot. All right, so here's the Entamoeba coli. The biggest thing with Entamoeba coli, this stage, is how many nuclei it can have. It can actually, it's the only one that can have up to 8 nuclei. And if you go back to the chart and go over on the Entamoeba coli side, 8 nuclei in the cyst, you'll notice none of the others have nearly that many. So that's a very big characteristic for it. And if you were looking at this under the actual microscope, of course, you would have to focus up and down. You're not going to be able to see all the nuclei on just one field. You kind of have to use your fine focus to kind of focus on other fields. So right here in this picture alone, I can see 1, 2, 3, 4, 5, 6 for sure on this. Again, it'd be easier if we had it under an actual microscope. The key signs of Iotamoeba bushlii is going to be this very large glycogen vacuole that it has. So the bottom pictures, I think, show it the best. You'll see this big round vacuole, and that's the glycogen vacuole. Again, if you go back, Iotamoeba bushlii was the last row, and over to the cyst stage, under the glycogen vacuole column, it says it definitely has a single defined vacuole, and you'll notice everything else really doesn't. So again, that should set Iotamoeba bushlii apart from the rest. And just a reminder, you may be thinking, well, what about diseases or anything else? The only one that was really pathogenic out of this list was Entamoeba histolytica. The rest of these are non-pathogenic, but we should still know and be aware of what they look like and how to separate them from the pathogen Entamoeba histolytica. All right, so, and then finally, Entamoeba hartmanni is our other one. This is probably one of the smallest amoebas. So the trophozoite stage kind of looks like a blob. There isn't a ton of really great defining characteristics to this one like there is the others. What I personally think to be true, and I've never really found this written anywhere, but from experience of every picture and every time I've looked at it or seen something and I know what it is, it has it. So when you look at the nucleus of Entamoeba hartmanni, do you see how very defined it looks, how dark it looks? It's a very prominent looking nucleus. It doesn't really blend into the background. It's very heavily defined. And to me, that's just the key part that I use to identify Entamoeba hartmanni. So I use kind of this really darkened nucleus that stands out to me as my key interpretation. Otherwise, there's not a lot to know. Again, it's a really small one. If you look, it's only 4 to 12 in the trophozoite stage. So it's pretty small. So there's nothing too exciting there about it. All right, so that is on those amoebas. Now we do have a couple other amoebas that are considered free living, so they're a little bit separated out from those other ones that we just went through. The first one is Blastocystis hominis. I do want you to remember this one. This can be pathogenic. It basically will have a central body. If you look at the very bottom of how to identify it, it's in bold. It has the central body inside of it that pushes the nuclei to the edges of it. So on the Blastocystis hominis, all the nuclei are going to be found right along the edge of the parasitic cell. So that's kind of a neat feature. And the way that students have remembered this in the past is you blast your nuclei to the edges. So Blastocystis hominis has a central body that blasts the nuclei to the edges. So if that helps you. This is a hard picture. I know it's not the greatest. I probably should find a better one. But you're not going to really see the edges of the central body very well. It kind of fills the whole thing. But if you look really closely, you can see a couple nuclei on the edges. There's one on the, I'm not sure if you can see my arrow or not. I hope you can. There's one right along the 7 or 8 o'clock, it's a clock. And then there's one over here along like the 4 o'clock time. So yeah, those are the two. You can see them right on the edge there. Here they used, I think this is an acid-fast stain they used on it to stain it. Where the red color is where the nuclei is. So you can see again, it's all right along the edges. All right, another free-living amoeba is acanthamoeba. I am not going to make you remember this one. It does cause encephalitis. So in the central nervous system, but I'm not going to make you remember this. And then Naegleria fowleri. I won't test you on this at this time. I probably should because it's something that's becoming more and more common to see. But for now, we're not going to test on this. But you should definitely be familiar with this guy because it has becoming big news maker. It's again another free living amoeba, and it's found in water. It causes amoebic meningoencephalitis, so part of the central nervous system, brain swelling, meningitis, that whole combo effect. The thing about this is because it's found in water, you can get it from swimming, and that's where it's made headlines. We never really used to see this a lot in the U.S., especially not northern parts of the U.S. because it's too cold. Parasites like warmth. But when I was living in Minnesota, we had several cases of happening in Minnesota, Wisconsin. And I'm not saying like several cases like, oh my God, it's like so common. You have to think there's thousands and thousands and thousands of people swimming every year up there. There's lots of lakes. A lot of those thousands, yeah, it's not that common, but when it happens, it makes headlines because of how significant the infection is. What happens is while they're swimming, they get this, it pretty much goes up the nose with water. So it goes up the nose right to their brain and settles in and does the meningoencephalitis. Unfortunately, it's fatal within 1 week of symptoms. That's where the significance comes in. It is a terrible parasite, and I don't know if there's any recovery from it once you get it, and that's the scary part. So that's why it pretty much makes headlines. We've had a few cases a couple years in a row with children, and it's just so devastating. And I think somebody told me that there was a case here in Arizona at one point. I don't remember when or where, if it was recent, but something definitely to be aware of as we're seeing more of it. It's maybe due to global warming. Maybe it's not as cold as it used to be, and that's why it can move more north for Minnesota, Wisconsin area. I don't know. But just keep it in mind, but we're not going to test on it as of this point. All right, so now that we're done with our amoebas, we're going to go into our next category, which is flagellates, specifically intestinal flagellates. So all of these are going to be acquired fecal orally. The two pathogens that are out of here are going to be Giardia lamblia and Dientamoeba fragilis. So those are the two intestinal pathogens. We are going to see other flagellates that are pathogens, but they're not going to be intestinal based. So just a quick note, Dientamoeba fragilis only has a trophozoite stage that we identify. We don't really see the cyst stage. So at this point, there's no cyst stage to worry about for Dientamoeba fragilis. Also, yes, it has the word amoeba in its name. It's really confusing. It's going to even look like an amoeba, but it is a flagellate. So keep that in mind. All right, so we will start with Giardia. Some of you have probably already heard of Giardia. It is something that we see in the U.S. It's the most common protozoan intestinal disease that we have, and it definitely comes through contaminated water. So a lot of times it can be contaminated well water. You see it in lakes and ponds because beavers are a reservoir of it. And it causes gastroenteritis and traveler's diarrhea. So from that contaminated water. So if you go somewhere and drink contaminated water, that's where you get it. So, all right. The trophozoite stage is going to be an oval pear shape with two nuclei. They kind of look like eyes, and we're going to call it an old man soon when you see it. It has this falling leaf motility to it. It has an axoneme down the center with two median bodies and lots of flagella. So when you look at a black and white picture here, you see the two nuclei, right? They definitely look like eyes, and you see the oval, or I should say the pear shape to the flagellate. And you definitely, it looks like a face, and that's how you call him the old man. As far as the cyst stage goes, we're going to see more pictures of him just in a second. The cyst stage will have four nuclei here. So if you look up here, there's kind of four nuclei in a cluster right by the letter F, if you can't see my arrow. And then and then it has an axoneme. It describes that here, two median bodies with the axoneme down the center. So basically, what I always think the cyst stage looks like is a flower inside of it. Like I think those four nuclei at the top clustered looks like petals, And then the axoneme and stuff looks like a stem and leaves, kind of. So that's how I identify the Giardia cyst, is that it's got the 4 nuclei as petals and then the axoneme as the stem. All right, so there it is stained. On the left is the trophozoite stage, the pear shape with the nuclei as eyes. You have to know both the trophozoite and the cyst stage of Giardia. Again, it's the most common one in the U.S., so you definitely need to know what you're looking at here. And then, of course, on the right is the cyst stage with the little nuclei, petals, and the flower. Here's the overall life cycle, again, coming through contaminated water, food, fecal, oral, passing, goes in, settles in your intestine, lots of diarrhea with it. All right, and then the other intestinal pathogen was Dientamoeba fragilis. Again, no cyst stage at this time that we're really aware of. The trophozoite stage is what we identify, and so it's going to look like an amoeba, kind of blobby-like, but again, it is a flagellate. You're just not going to see the flagella coming off of it. It will have 1 to 2 nuclei, and in each nuclei, it has 4 to 8 chromatin granules. And I bolded that because that's very key on identifying Dientamoeba fragilis. So if you look at it, both A and B are Dientamoeba. In letter A, do you see how heavily dark those 4 chromatin granules come? So that's the nucleus with the 4 chromatin granules. Over here in letter B, you can see there's 2 nuclei, and each has at least 4. It just might be harder to see all 4, but you can see the dark granules, and then there's more than one. There's usually at least 4 of them. So that's very diagnostic for Dientamoeba fragilis. Again, here you see it stained. On the left, it has 2 nuclei with 4 chromatin granules staining more pinky. And then on the right, you see 1 nuclei with the chromatin granules inside of it. So do be able to identify Dientamoeba fragilis. All right, so on to our next set of flagellates. We have Trichomonas. Now, these aren't necessarily intestinal pathogens anymore. They're just other flagellates. So Trichomonas hominis, trophozoite stage only, no cyst stage with this one. It's non-pathogenic, so there's no disease here to remember. And in fact, this is going to look just like our next Trichomonas in that it has this undulating membrane on the side. So this is just a drawing representation of it. So it is a flagellate, so you can see the flagella coming off, axostyle down the center, but it's this undulating membrane. Undulating means wavy. Wavy membrane on the side, and all the Trichomonas are going to have that. So you're not going to really need to remember Trichomonas hominis because there's going to be another Trichomonas that we're going to remember instead. But they look like. Just a note, just remember Trichomonas hominis, no cyst stage. So I'm actually going to come back to this one real quick. Wait, did I not have? Maybe I deleted those slides. I'm so sorry. I thought I had. I just have to look real quick. I know. Okay, I guess I didn't have a slide on it. Let me skip down a couple to this chart again, just so I make sure. The one that is definitely pathogenic, that's a Trichomonas, is at the very bottom. Trichomonas vaginalis, so you maybe heard of this from urinalysis or in just general because it is an STD. So this is the one that is definitely pathogenic. It is urogenital pathogen. And so it has that, you can see that undulating membrane off the side, just like Trichomonas hominis. But you are going to see this found in urine, and that's where it says found in urine under other features. And it can also be found if they were to do like a wet prep, so swab a vaginal specimen. You can see it in that if the woman has picked up STD, Trichomonas vag. So it has a very jerky kind of motility, but definitely can see it in urine. It'll be there, and you will see it. It's unfortunately common, so definitely be aware of Trichomonas vaginalis. Don't worry about the cyst stage or anything. It's just the trophozoite look with that membrane off the side. All right, so now we'll go back to our next flagellate, which is Chylomastix mesnali. This is non-pathogenic, but I do want you to be aware of it and remember it. In the trophozoite and stage, it'll have what we call a shepherd's crook. It'll have this, basically these fibrils that curl, and they make this shepherd's crook. So if you think of Mary had a little lamb, and she always held that hook in her hand, that's what a shepherd's crook looks like. As far as the cyst stage goes, it's kind of like a lemon shape with a knob on it. So there's kind of the cyst. It's not that exciting. There's not a lot of features here to it. And then we will see pictures in class of the shepherd's crook and all that. I guess I didn't put it in here, but you can kind of see it. It's in here in this little chart. So you do see the shepherd's crook kind of in the cyst stage a little bit as well. So I think the drawing of the cyst is really good because it definitely shows that lemon shape. All right, so this is a nice summary of all the flagellates that we just went through. So again, I do actually ask that you know all of these on this. All right, moving to ciliates, there's only one ciliate that you're going to have to remember, and it's the only one that's pathogenic, and that's Parasitology coli. Again, fecal-oral transmission coming through contaminated food or water. It is the largest of the protozoan classification of parasites. It's a very large parasite. And of course, it's going to move by cilia. So as a result of fecal-oral, that kind of thing, you know it's going to infect the intestinal tract, cause diarrhea. We kind of get that. As far as the trophozoite stage, it's going to be very large, and it's going to have two nuclei. One is going to be what we call a macronucleus, which is going to have a kidney bean shape to it. It should be very obvious. And the other one is going to be a micronucleus, just one small round nucleus. And that sometimes doesn't always come through and show. So there it's kind of showing the nuclei there. And then, yes, it's covered in cilia. Are you going to really see the cilia always? No. No. Look for the macronucleus. That kidney bean-shaped nucleus is going to be so key for you. So there it is, stained. You can see how obvious that kidney bean macronucleus is. And it's just a very large parasite. So be sure to remember Parasitology coli. There it is again. It's kind of just showing you a trophozoite and a cyst stage. Both are going to have that kidney bean-shaped macronucleus, so that's what you're going to use. All right, going back to some other flagellates, these are going to be blood and tissue flagellates specifically. So they are going to be passed by a vector, so like a parasite, not a parasite, like a fly or mosquito or something like that. And now we're kind of using different terms for the stages. In this case, we're referring to amastigote, trypomastigote stages. Amastigote is going to be an obligate intracellular. That's going to mean it's only found inside a cell, and there's definitely going to be one that we will look at. A trypomastigote can be outside of the cell and will be found just in the blood or lymph fluid or even the cerebrospinal fluid. So those are kind of just some terms. As far as the ones that we're going to discuss both leishmania and trypanosoma. So this is just kind of showing you a little bit of the stages, what an amastigote stage looks like compared to a trypomastigote. And then you're going to notice the vectors that pass them. So for leishmania, it's going to be the sandfly. And then for trypanosoma, there's actually two different ones. It depends on which trypanosoma that we get. So we're going to go through all of that. So don't worry about this because we're going to get into all of it. So we're going to start with leishmania. And there's actually 4 different leishmanias. There's Tropica, Braziliensis, Mexicana, and Donovani. The amastigote form is going to be the one, again, that's intracellular. We're going to see that inside macrophages because what they do is they kind of phagocytize and they go in there. Again, passed by a sandfly. Please remember that vector. So dogs and rodents are typically the reservoir hosts for leishmania. So you're going to find that leishmania in general is going to cause a lot of different skin, mucous membrane type destruction and ulcers. So we're going to start with Leishmania tropica. Name that because it causes cutaneous leishmaniasis of Old World. When we say Old World, they are referencing the area of Asia, essentially. So you can see the nasty cutaneous sore on this person's hand here. That's kind of the damage it does in the, so again, these are tissue and blood flagellates. That's where they're going to reside, and then that's where they're going to cause disease. So it's going to eat through that tissue, and that's where you see the cutaneous sore come up. Leishmania Braziliensis, Brazil for New World cutaneous leishmania. So now we're over in South America. So again, another kind of cutaneous lesion and where it eats through that tissue there. can especially happen anywhere. It doesn't have to be like on just one area. It can be face, extremities, anywhere. Leishmania mexicana, the name tells you it's kind of more Mexico, Central America. This is mucocutaneous leishmaniasis, meaning it will affect where the mucous membranes lie, such as your nasal area, as you can see on this person's face. So very disfigurement of the soft tissues. And then Leishmania donovani is visceral leishmaniasis. So this occurs many different areas. And this is probably the most pathogenic, the most disease-causing. I can't remember what I was going to say there. But basically, it doesn't just stay on the cutaneous or mucocutaneous. It can spread throughout to your different organ systems. So if you think about the damage that was just done to that skin that we saw or to the mucocutaneous, that's what it actually can do to your organs. So you can see how disease-ridden it can really be and how severe. Again, fatal within 2 years. Well, I would think so. If you're damaging your organs, they're going to eventually fail on you after a amount of time if you don't get treated. And then this is the part where a lot of people are like, well, don't they get help? Or yes, of course, they'll try to get medical help. But again, think of all the areas that we've mentioned where this is occurring. A lot of those areas contain countries that are third world, that are poor, that don't have a lot of great health care, a lot of great healthcare insurance, things like that. So you have to kind of put that all into perspective of why it can get so severe and why they have a hard time getting treated, or maybe they don't have healthcare near them, whatever it might be. All right. So kind of know each one of those four, what it basic causes. And then again, they're all passed by the sandfly. So here's a little life cycle with the sandfly in action. So the way that we diagnose this is actually seeing the amastigote inside those macrophages in the skin lesions or biopsy. So if somebody were to come in with a cutaneous lesion like that, you could biopsy that lesion, and then you would look for those amastigote form in the macrophages. So here's what they're going to kind of look like, those little round things. They're just small. They're only 2 to 5 micrometers in size. They're going to have a large red nucleus, which is what you're seeing in each one of them. So there's another picture. You're going to start to see them more in the cells here. And then there's a great one with them definitely inside that macrophage. If you were to see them in the promastigote form, again, that was the amastigote form. The promastigote is outside of the cells. It can swim along. It is a flagellate, so you do see the flagella here. This is what it would look like. To me, they kind of look like little mice with tails. I don't know. Think of all those little mice scurrying around. But anyway, we are looking at the amastigote for a diagnostic form. So that is the form you need to remember, is the amastigote form. All right. Our other blood flagellate, also going to be part of cerebrospinal fluid, is trypanosoma. There are going to be 3 different trypanosomas here, and they are going to be passed either by the tsetse fly or by the reduvid bug. So we'll go through each. First, we have the 2 sleeping sicknesses. We have West African, which is caused by Trypanosoma brucei gambians, and you have East African sleeping sickness caused by Trypanosoma brucei rhodesians. And then the other one, the Trypanosoma cruzi, causes Chagas disease, which very much is found here in America. So you can sometimes know it as American trypanosomiasis. All right, so let's get into first. I think I'm going to come back to that kissing bug in a second. Let's go first into the sleeping sicknesses with Trypanosoma brucei. So again, there's 2 different ones. You have the West or the East African sleeping sickness. The symptoms with this is basically when they contract this disease, it's going to be contracted by the tsetse fly. That's the vector, the tsetse fly. We don't have a tsetse fly in America, so we don't see this over here. It's over in Africa. But when it infects them and passes along the parasite to that patient after it bites them, it will go and set up camp in their lymph nodes, and it causes lots of lymph node swelling. It can go into the blood, and so you'll see the lymphadenopathy with the lymph node swelling, headache, weakness, fever. You'll get this, what they call post-cervical lymph node enlargement. So right in the neck, there is this specific lymph node enlargement that occurs that's called the Winterbottom sign. It's a classic finding for sleeping sickness. It looks like that. I don't expect you to remember that. It's just FYI. And then if this were to continue, not get treated or caught right away, it can involve the central nervous system. And so as a result, this is where the sleeping sickness name comes in. So extreme fatigue, mental dullness, increased sleepiness, and finally coma and death if it continues and doesn't get treated. All right, so there's the overall life cycle of Trypanosoma brucei with being passed by the CC fly bites. Here's the canker, shanker, however you want to say it. I should look up how to actually say that word. The CC fly bite. It's a nasty little bite. Oh my gosh. All right, and then again, diagnosis. Because this can be found in the blood or the lymphatic fluid or cerebrospinal fluid if it gets that far, we can look in any of those three fluids for the parasite. So we usually look for the trypomastogote stage is what you're going to find. It's 15 to 20 micrometers with a large nucleus, and we just say it's trypanosoma. You can't, like it says here, it's geographically dependent. It depends on which region you discover. You'll know which trypanosoma it was. You're not going to be able to tell them apart by looking at it. They look identical. So here it is, down there. I think they are so cute. I feel like I love trypanosoma. It's my favorite. I'm going to say it all the time. You're going to get sick of me saying it. I love it. It looks like little seahorses to me. No, I wouldn't want it. I just think they're cute. Look how cute they are. They look like little seahorses. So yes, you do need to know trypanosoma. All right, and then the other one was Trypanosoma cruzi. As far as adults, this doesn't affect adults as much as it affects children and can cause even it evades multiple organ systems. So you do have a classic sign here as well, in which it'll cause a specific swelling to the eyelid called Romana's sign. I think, yep, I have it right there. So that's something that's well known to go along with the Trypanosoma cruzi infection, conjunctivitis, along with that eyelid swelling. You see a lot of the same, like muscle pain, not feeling well, lymphadenitis, so lymph node and swelling, damage or enlargement of the liver and spleen, so on. So, and then it can go into even more of a chronic phase, cardiac nerve, because it can go to different organ systems. So it can cause damage to each of those systems wherever it goes, essentially. Again, Trypanosoma cruzi is passed by the rejuvid bug, which is known as the kissing bug. I'm going to go back up to here. So the rejuvid or kissing bug, and this is what it looks like. Definitely something we get in America. So the penny is there just to give you the size of the bug. And maybe I'm crazy, but I feel like I've seen that bug a lot. All right. So that's Trypanosoma cruzi life cycle with the bite of the rejuvid bug, and it passes. And again, we are going to detect it in the blood, and you're going to see the trypomastogote stage. And it's going to have more of a C or U shape than the other Trypanosoma brucei right there. They say that's more diagnostic. To me, I just need you to know it looks like trypanosoma. And then, of course, travel history and signs and symptoms are all going to come into play in which trypanosoma it was. If they've never been out of the United States, they're not going to have sleeping sickness. It's obviously going to be Trypanosoma cruzi. So, again, they do say it represents more of a C or U shape on the cruzi part, but just know it's trypanosoma in general. They look pretty identical otherwise. All right, Plasmodium, which is malaria. If you've had hematology, you should have learned some of this there. It's something I usually taught more in heme than micro, but we do need to know because it is a parasite. So, of course, you have 4 malarial parasites, Plasmodium falciparum, Vivax ovale malariae. So it kind of shows you where you see them. Now, we don't have malaria here, but because people travel so much, we are going to see it diagnosed here. So because we have people that travel quite frequently now, they go on trips. If they go anywhere there's malaria, which is like Africa and the southern parts of Asia, they could pick it up, and then when they come back, they're sick and go into the doctor, and we can be the ones to diagnose it. So you still have to know how to look at this and diagnose it. So malaria, as you probably have learned in heme, it affects red cells, and that's why we teach it in heme, and it causes significant hemolysis to those red cells. It uses the red cells to mature, and then it destroys them and goes to the next and the next. So it's a cyclical fever. As it's lysing those red cells, that's when it's causing a fever. When it's not lysing the red cells, they don't have the fever. That's the cyclical part of it. You're not going to have to remember the frequency of the cyclical fever down here. It's just informational. Again, it is a hemolytic process, so it's going to be definitely a hemolytic anemia. All right, so there's kind of the different stages of malaria. It starts with the ring stage all the way down through the trophozoite to the Schizont stage and then to the gametocyte stage. So it'll start as an asexual reproduction, and then the gametocytes are sexual, male and female based. So each malaria might look a little different. So here it just kind of sums up and compares all of them. I would remember for future, especially for boards, in the Schizont stage, they are differentiated based on how many merozoites they have in those stages. I would remember that in the future. The ring stage kind of looks alike in all of the malaria. They all have a kind of an identical ring, except for falciparum. Falciparum is unique in that it can have 2 little chromatin dots in the ring stage. All the rest have 1. And then the trophozoite stage, the one that really stands out is a malariae. It's the only one that can have a band across the red blood cell. When you see it, it's inside the red cell and have this big band that just stripes across that red cell. That's unique for malariae. None of the rest really have that. And then the other stage, gametocyte, is unique in the falciparum, that it is a crescent-shaped gametocyte, or you can call it a banana shape, if you will. So that's unique for the falciparum. All right, so here's Vivax. You can see the ring stage is A, then you got trophozoite, and then you have Schizont, and so on. So I'm not going to test you on Vivax. I just want you to recognize when you think you know it's malaria, especially for the ring stage. There's malariae. Letter A is supposed to show that band trophozoite. I know it's not that great looking. There's falciparum, and there letter B shows you the gametocyte. That is the banana or crescent shape. So that you definitely need to remember. I would remember that, and I'd also remember that it can have the 2 chromatin dots in the ring stage. All right. Babesia, another parasitic infection, definitely found in the U.S., passed by ticks. By the way, malaria, of course, is passed by mosquito. Again, Babesia passed by ticks, specifically the Ixodes tick. So anywhere where you have a lot of ticks, you can have potential of Babesia. So again, also infects the red cells, causes a hemolytic process, but it's not cyclical. It's a straightforward fever and things. So it's going to have a ring form look to it as well, very similar to malaria. So you got to be careful on if you're calling it malaria or Babesia, if it's just the ring stage, because they look similar. The key to Babesia is when it gets this tetrad look with the rings that we call a Maltese cross. So on the left, you're seeing just some of the ring stage look to it, very similar to malaria. On the right, you're seeing that tetrad, that Maltese cross. That's very characteristic for Babesia. So definitely be aware of that. Toxoplasma gondii, if you're in immunology, you probably just heard of this. So it is a parasite. This is the one that is passed by the house cat, which is why pregnant women can't clean litter boxes, because it would cause huge infection to the fetus. So congenital infections are the hardest, or anybody that's immunosuppressed, really. So I am not going to make you remember Toxoplasma gondii, but again, it's passed by fecal oral route. There's gardening, changing litter box, sandboxes. Well, let's be real. Sandboxes are just outdoor litter boxes, really, unless you keep it covered, which I hope you do. Or it can get organ transplants, that kind of transmission based. So there they are. They're not very big. They're very small, little oocysts, we would call them. So you're not going to have to remember this, because mostly we test by blood for Toxoplasma. There's a whole panel of blood work that is done when somebody's pregnant to screen for different diseases that are known to cause huge congenital problems. And Toxoplasma gondii is one of them that we screen for in pregnant women. So again, it's typically an antibody-based testing that we do, not so much looking at for the parasite. But you can, if we think that there, we can take a tissue biopsy and look for it. But again, you're not going to have to remember this in micro here. This is more something I test in immunology. All right, the next group is Coccidia. We have Isospora, Cryptosporidium, and Cyclospora all present in this category. These are really harsh on immunosuppressed patients. You're going to see them more commonly linked with AIDS patients. Again, a fecal-oral transmission. Out of these three, the only one that I'm going to make you remember is Isospora. We're going to go through the three, but Isospora is going to be the one to remember. All right, so starting with Cryptosporidium parvum, definitely seen in waterborne outbreaks, which will cause epidemic diarrhea. So you're going to see a large population have this if there is a big waterborne outbreak with it. So you are going to see oocysts that cause the infection. Whenever you ingest those oocysts, that will cause the infection. Again, it's a diarrhea-based disease, so they're going to set up camp in your intestines. All right, so that oocyst is what we're going to see in the stool. If we suspect this, we can acid fast stain the stool and look for it. There is a fluorescent method as well, but that's what it would look like with acid fast on the right. You do not need to remember this. I would just, in the future, remember Cryptosporidium parvum as a waterborne outbreak. It is something that we see in the U.S., but for now, we're not going to remember it, but I would remember and relook at it for future boards, when you're studying for your boards, that kind of thing. All right, and then Isospora belli got renamed. I hate it when they do that. So now it's Cystoisospora belli. It's the same thing. We're going to call it Isospora belli because that's what I'm used to. So again, it's basically going to be waterborne outbreaks. Immunocompromised patients are our biggest risk with this. So finding the oocysts in the stool, again, you can acid fast stain it if you will. In this case, though, they're going to be more oval in shape with a hyaline cell wall. Hyaline means like a clear cell wall. And then inside, you're going to see these sporocysts. So there it is on the right with acid fast. Here it is with no stain. I do need you to remember Isospora belli. So it's kind of got that large sporocyst. You can have one of them or you can have two of them inside there, and then everything else is pretty clear. And then the other one was Cyclospora cayetanensis. This is from contaminated foods like strawberries, raspberries, basil, lettuce leaves, peas. This is the reason you need to wash your fruits and vegetables if they're fresh, because it can have parasites on them. So again, oocyst, not going to have to remember this one at all, but there is what it looks like. All right. Keep going. We're going still. On to the worms. We're finally into worms. So we have two categories here. We have our nematode, which is our roundworm, and platyhelminths, which are flatworms. And the flatworms can either consist of what we call flukes or tapeworms. And so all of these are going to be a fecal-oral kind of passing transmission and basically diarrhea happening. So disease-wise, it's easy. I mean, that's just one big, large diarrhea incident. But how to identify each one is where it gets to be the trickier part. All right, so flukes, again, reside under the platyhelminth category. When we talk about identifying these, we are identifying the eggs of the worms. Yes, if you get the worm itself, you can identify it, but for our purposes in this class, we are going to know the egg look. All right, so here is all your flukes listed in one summary. On this, the ones that you need to remember are actually all of them. I hate to say that to you, but it is. You'll notice that Heterophes, and Metagonomus yakagawa don't have a picture here. You're not going to need to remember a picture of them, but there is something I'm going to ask you to remember on them. But otherwise, all the others, we definitely are going to need to know the way they look. So we're going to go through each one. We're going to start with Fasciolopsis busky. It's a giant intestinal fluke. Dogs, pigs are kind of the hosts of it. Again, transmission is fecal-oral. Anything that's contaminated, you can get it from eating raw vegetation like water chestnuts, bamboo shoots. So diarrhea, it's an intestinal fluke. So we are looking for the egg as in the stool sample as our diagnostic. Again, if you get the actual worm, great. But as far as the egg goes, there it is. You're going to notice at the top of the slide, I named it Fasciolopsis busky and Fasciola hepatica. And the reason for that is they both have an identical egg. You cannot tell this egg apart on either one. So that's important for you to remember. It's the same. It looks identical. They both look like this. There's nothing exciting here. I can't tell you anything distinguishing on this. You just kind of have to remember the way it looks. All right, you're going to also notice here Metagonymous, Yakagawa, heterophyes. I am not making you remember the look of these. All I want you to remember on these is their egg looks identical as well. So you cannot tell Metagonymous apart from heterophyes. It looks identical to each other. But I don't want you to remember the egg. There it is again, that Fasciola hepatica and Fasciolopsis busky egg, unstained. That's the heterophyes and Metagonymous one. Again, you do not need to know the picture, just know that their egg looks identical. All right, here's just a mention on the Fasciola hepatica. It is a liver fluke, that's why it's named hepatica, and it also comes from raw vegetation. So as it says in bold at the bottom, indistinguishable from Fasciolopsis busky. So just know the look of this. All right. On to our next one, Clinorchus sinensis. They had renamed this. I will always call it Clinorchus sinensis. So that's what I would remember if I were you. All right, this is the Chinese liver fluke, is its nickname. So again, a raw or undercooked fish and causes diarrhea. So the egg is going to have this operculum with clearly demarcated shoulders. So operculum is kind of like a cap-like covering to the egg. So that's what is really significant about identifying Clinorchus. So here you're going to see it, and I hope you can see my arrow on the left side, the operculum, this cap-like covering, and then you're going to see this notch here to here. Those are the demarcated shoulders. And so you have to know it's Clinorchus sinensis. Here it is again. I know it's a little blurry here, but at least on the top here, you can kind of see those shoulders better. And then the operculum, the covering there between them. All right, lung fluke is Paragonimus westermanni. It's nicknamed the Oriental lung fluke. I would remember it's a lung fluke because if they are having respiratory symptoms and they have Paragonimus, you could actually find this in sputum. So it can be found in stool when it's passed, but it can also be found in sputum since it is a lung fluke. It comes from undercooked crabs or crayfish. All right, so eggs found in sputum, sometimes feces is swallowed. All right, so the look here is it has an operculum with very small shoulders, but a thicker shell at the opposite end. So on the bottom of this is the operculum, and then as it gets to the other end, it gets a really thick shell. So you do need to know Paragonimus westermanni. There's not else much exciting on this one. There it is again. I know it looks similar to Fasciolopsis, but it's not. So just do the best you can with Paragonimus. All right. One thing I should mention on Paragonimus is sometimes you can see the individual insides. I have a picture that we'll look at in class that maybe will help show that. All right, and then our other flukes are blood flukes. So these occur in different intestinal veins. So large intestine vein, bladder vein, or small intestine vein. So you can see them in the stool when they're passed as well, or and then also in urine. There's one specifically for urine especially. So there's 3 species, all are schistosoma, and we have Schistosoma mansoni, hematobium, and japonicum. So the key is going to be that there's going to be a spine to these. The way that you get this, by the way, is swimming. It'll be a direct penetration of the skin while swimming. That sounds fun. All right, so there it's just kind of going over the disease part of it. Schistosoma hematobium here at the bottom is the one that you can find in urine because it occurs in the vein over the bladder. So you will see urinary symptoms with this, painful urination, hematuria, dysuria. Just kind of a note on that. You should remember hematobium is the one that is also found in urine. All right, so let's go through the look of each of these. The nice thing is these are more identifiable than some of the others. Schistosoma mansoni is very well known for this large lateral spine. So you can see that little spike coming off the side. That is the key to identifying it. Schistosoma hematobium is known for the terminal spine, so it has it at the end. And then Schistosoma japonicum, a very small, and I mean small, lateral spine. So small it's hard to see. If you look at it on the left, it's actually on the very bottom, and then I zoomed it in here. It's right there It's kind of laughable that that's a spine, but it is. All right, so know those three. Here they are all in representation. Don't ask me where the spine is on letter C. I don't even know. I'd have to zoom in with a microscope. So I can't tell you at this point, but it is there. Okay, next is tapeworms. So tapeworms are named that because they are long, segmented, ribbon-like. I'm pretty sure we've all heard of tapeworms. And if you're not realizing it, in the 80s, there was a huge tapeworm diet movement where people had purposely give themselves tapeworm to lose weight. And I cannot believe that they willingly want those things in them. They are disgusting. But fecal oral transmission is the way you get it if you don't purposely put it in. Ingestion of contaminated food. So as far as what a tapeworm looks like, this is kind of a nice little diagram. So on the segmented part to the actual worm, we are going to call these segments proglottids. So if you look over on the right, it says that word, proglottid. So each one of these little segments is a proglottid. And inside that is eggs, the female and male sex organs, all that kind of works. So we actually can differentiate different tapeworms if we see the worm based on the number of proglottids it has. So those number of segments do become important in diagnosing. Up at the very top, there's usually a scolex, which means how it attaches. And so sometimes they'll have hooks, and sometimes they'll have suckers. Sometimes there's a neck. So it just depends on each worm what it will or will not have. So just kind of an FYI and the basic look of a tapeworm. So here are all the tapeworms that you do need to remember. So we have the Taenia saginata is a beef tapeworm. Taenia solium is a pork tapeworm. The Taenias look identical. You cannot tell apart a saginata from a solium based on the egg. You would actually need the worm itself to know if it was a saginata or a solium. So we would need the worm itself to identify that. Otherwise, when we see a Taenia egg, you're just going to say Taenia because you can't tell which one it is. Diphyllobrothium latum is going to come from raw freshwater fish. Hymenalepis nana is tapeworm eggs. I got to change that. Diminuta more grain beetles. I wouldn't worry about that. You're going to need to know the look of the Hymenalepises, but don't worry about that. And then Dipylidium cadenum comes from fleas from dogs or cats. All right, so here's your nice little summary of the tapeworms. You do need to know, again, all of these. So be sure to go back and read the identifying features. It'll help. It kind of shows you a nice picture representation of each one. So I might flip back to this slide as we talk through. All right, so we'll start with Diphyllobrothium latum. Again, raw freshwater fish. So it is kind of known as the fish tapeworm. You can see this in the Great Lakes area. So it's just important to always cook everything. All right, so there's kind of what it looks like. Now, when you go back to this chart, it's going to talk about how it does have a operculum, that kind of cap-like covering, but it's an inconspicuous, meaning it is not going to be obvious that it's there. It is there, but it's not totally obvious. And then a lot of times it'll have this small knob at the opposite end. It is unembryonated, so there's not like a thick wall or anything here to the actual egg. So those are the key features of Diphyllobrothium latum. So if you look at this one, this arrow is pointing to where the operculum lies. I could barely see the line of it. It's right there, and then there is a knob at the other end. That knob is not like an obvious knob like the diagram shows. It's a subtle knob. So you do need to know Diphyllobrothium latum. The knob on this one is better. On the right there, you can see the knob much better. All right, Taenia, again, Taenia saginata is beef, Taenia solium pork. Again, because the eggs look alike, you have to know the look of the worm to identify. So as far as the saginata worm goes, it has 4 suckers to its head, no hooks on the head, no neck. Whereas the Taenia solium worm has 4 suckers, but it does have hooks around and a neck. So that's kind of how they identify the worms apart. Now, these cause a lot of diarrhea type illness, but Taenia solium is also known to cause what we call cysticercosis, which you see in bolds. And if you go to the CDC, by the way, CDC has amazing parasite pages. It has a whole page dedicated to cysticercosis. This is something that there is a board question on this, so I always like to mention it. because there is board reference questions on this. So cysticercosis caused by Taenia solium cyst, what happens is instead of going to the intestines causing the normal diarrhea, they actually can go up and infect the brain, muscle, or other tissues. As a result, they cause seizures, that kind of thing. So it does cause other CNS type stuff, not just diarrhea type stuff. All right, as far as the egg itself, though, how to identify Taenia, it's a very thick shell with radial striations. If you go back to the drawings, you're going to see those radial striations in that thick shell drawn out there. So let's look at a real life look of that. And there is a Taenia egg with the radial striations. So please know that. This one, I should just delete this picture. It's a terrible picture. Ignore that picture. These are better pictures here. All right, and then our Hymenolepises. We have two. We have Nana and Diminuta. Hymenolepis nana is known as the dwarf tapeworm. It's kind of small. And the key on this is whether they have these polar filaments or not. Hymenolepis nana does have polar filaments, whereas Hymenolepis diminuta has no polar filaments. So I want to go back to the drawings. So you can see that here. On Hymenolepis nana, you're going to have two polar knobs and usually four polar filaments that extend off of those knobs into that space. Whereas in diminuta, there is nothing. It's perfectly clear. So that's the way that you tell apart the Hymenolepises. So here's Hymenolepis nana. Two, you can see it's kind of like, it looks junky, but they are polar filaments in that area. There again, it's not as easy to see. They're there. Whereas Hymenolepis diminuta, do you see how nice and perfectly clear that is? And again, nice and really clear. All right, and then lastly on this topic is Dipylidium caninum. Again, coming from fleas off dogs or cats, it's usually known as a dog tapeworm mostly. In this case, it's not just like one singular egg, it's a packet of eggs. A lot of times there could be 15 to 25 eggs in that packet, which is really gross to think about. So that's the look of Dipylidium, very unique in that it's that packet of eggs. So I would be familiar with that as well. Okay, next are tissue cestodes. You have Echinococcus. I am not going to test you on Echinococcus, so you do not need to remember those at all. And then it just re-mentions again, Taenia solium can be found in the tissues because they can go up and also into the central nervous system type thing. So it's just a re-mention of that. So there's Echinococcus granulosus. It's a very small tapeworm. It only has 3 sections, 3 proglottids, as you can see. So again, do not worry about the Echinococcuses. On to our intestinal nematodes, which are more the roundworm section. First, we have hookworms. You're going to see them, we're going to diagnose, again, eggs and stool, just like always. But the 2 hookworms that we have are going to be called Ancylostoma duodenale and Necator americanus. They also look identical to each other. So if you were to see one, you just simply state hookworm present, because you cannot identify which hookworm it would be. So you just say hookworm egg. Again, ingestion of contaminated food, water, fecal, oral, or in the case of this, it could also be penetration of the skin by larvae in the soil. Always wear your shoes, people. Wear your shoes. All right, so here's all of our nematodes all together. You do need to know all of these. So we have Enterobius vermicularis, which is pinworm. You definitely need to know pinworm. I mean, you will see that at some point if you work micro long enough. You diagnose this through a Scotch tape method, so we'll discuss that. You have Trichuris trichura, which is whipworm, Ascaris lumbricoides, roundworm. Strongyloides stercoralis is threadworm. The unique thing there is it's passed as larvae. Typically, we're looking for eggs on all these, but with Strongyloides, it's a larvae that we'd look at. And then again, your 2 hookworms, which are Ancylostoma duodenale and Necator americanus. So there's our nice summary chart again. At the very bottom is Strongyloides is mixed in there, but there's a couple here that you don't need to remember. All right, so let's go into it. Enterobius vermicularis first. It's, again, the pinworm. Typically affects mostly children. And this is the one where if you see anal pruritus, pruritus is just a fancy word for itching. A lot of anal itchiness with this because what happens is the female at night will come out and lay eggs around that anal area or anal opening. And so it makes for a lot of itching. So all you literally do is what they call a scotch tape or cellophane tape method. So you simply, the doctor, the nurse, whoever, will take tape and go right around the anal opening with the tape. And they're hoping to pick those eggs up that are laid there. And the eggs will be on the tape. They send it to the lab. We put the tape on a slide onto the microscope, and we look for eggs. If there's eggs, they have pinworm. If there's no eggs, they do not have pinworm. It's as simple as that. It is amazingly simple. So again, we are going to look at the eggs. Real quick, the adults are named pinworm because they have a pointy tail that looks like a pin. But the eggs itself are going to be colorless shell, flattened on one side, and you're going to see the larvae inside the egg. So there's the pinworm. You don't need to worry about the worm. But here is the egg that you do need to know. So it's flattened here on the left side, and the larvae is the inside part here that you're seeing. There it is again. So do know pinworm, Enterobius formicularis. All right, our next one is whipworm named Trichuris trichura. In this case, again, more diarrhea. Imagine that, guys. So it is called a whipworm, by the way, because the worm itself literally looks like a whip. It's so disgusting. But again, for the eggs itself, the eggs are going to have what they call these prominent polar plugs on each end, and it's bolded because that's so characteristic looking for Trichuris trichura. So there they are. I think the unstained one looks better than the stained. So you can see the polar plugs on each end. There it's even better representation. So this should be pretty unique from all the other parasite eggs, so it should be easier to identify. The way that students have remembered this in the past is they think it looks like a casserole dish, like the polar plugs are handles on each end. And so they would say you whip up a casserole to remember that Trichuris trichura is the whipworm. So if that helps you, I hope so. All right, Ascaris lumbricoides is the roundworm. Again, more larvae, oh my gosh, more diarrhea. I've been talking too long. More diarrhea on this. So in the eggs on this one, they're going to have a thick, transparent shell. The roundworm looks like what you literally think a roundworm, kind of like an earthworm. But there is the shell. I feel like the shell is very bumpy looking, and to me, that's what I try to look at is kind of how bumpy it looks. Let's see. I want to go back real quick to that summation slide. Up here, the fertile. Yeah, bumpy, or they call it mammillated. What a fancy name. Wow. Usually it's kind of bile stained, so it has that brownish look to it. And that's the fertile egg part. There is an infertile. I'm only going to make you remember the fertile version. So they kind of look like this bumpy. Yeah, so I was right when I said bumpy. Look at that, you guys. All right, so remember the bumpy look here to it. These are not as obviously bumpy, but they're a little bit on this one. Kind of have to really look at the edge of it and just kind of rule out anything else that it could be. And then finally, our hookworms. Again, you just call it a hookworm egg because we cannot distinguish between the two. They look identical. So they're going to be thin, clear, smooth, colorless shell. There's what the actual hook part of the hookworm looks like. That's why it's named that. It hooks on. So there is nothing exciting about this egg. It's just, as you can see, a very clear shell around it. And then it did say the contents could be disorganized, I think. Disorganized globular content. So it's like they're not always in a nice look. The inside isn't going to look identical every time. It's just this nice clear shell. But they can look kind of different in each version. But do know hookworm egg. And then Strongyloides stercralis is the threadworm. This is the one that doesn't really pass as an egg, passes more as a larvae. So we are going to usually look for the larvae form of it. So that's what you need to remember here. It's the only larvae form that I'm going to ask for you to remember, so it should be a little simpler. There it is again. All right, let's move on to worms that are found in the tissues. So all those were intestinal type based stuff more. But trichinella is a tissue worm from raw pork or raw bear, who knew, found in muscle. So if you suspect this, you would do a muscle biopsy looking for this worm in there. It's always kind of in a spiral look to it like this, so it's very unique that way. Should make it a little easier to identify for you. There's kind of what a muscle biopsy would look like, and then they look for the worm in there. All right, and finally, some other worms. We have a grouping here: Brugia malayi, Wucheria bancrofti, Onchocerca volvulus, and Loa loa. These are going to be identified by what we call microfilariae. So here is the chart. You're not going to have to know all of these. You don't have to worry about the Manzanellas at the bottom. Just the Wucheria down through the Onchocerca. So they all are passed by different vectors. So Wucheria bancrofti passed by a mosquito, Brugia also passed by mosquito, Loa loa fly, and Onchocerca a fly. All right, so the way that you identify between these is based on if they're sheathed or not sheathed, and where the nuclei stop in the tail. So in Wucheria bancrofti, it is a sheath, microfilariae, and the nuclei do not go all the way to the end. They stop before that. Whereas in Brugia malayi, it's sheath, but it has two kind of terminal nuclei that are separated, so individuals separated between those nuclei. Loa loa is sheath, and the nuclei go all the way down to the tip of the tail. And finally, Onchocerca is not sheath, so there's no extra sheath or coating around it. All right, so Wucheria bancrofti causes elephantiasis. This is where basically when it's passed to you by a mosquito, it will go in and settle into a lymph node area in your body and cause extreme inflammation in that lymph node. So you have lymph nodes all over your body. It just picks where it likes to settle. Typically, it's in the lower extremities or even the genitals, and that's when it causes the extreme inflammation. So again, to diagnose this, you're going to look for the microfilariae with nuclei that do not extend into the tail. They stop before that. So there's kind of a look, and if you look here, the tail keeps going on the right. It's hard to see, but there's no nuclei going to all the way to the tip of it. So there on the left is a better picture where you can see that it stops at some point, and the tail still goes. The one on the right doesn't really show the tail end of it, so it's hard to tell. But you'll notice that this is collected in a lymph sample, a lymph fluid sample, or sometimes you might see it pop up in blood as you see here. And again, like I said, extreme swelling, so that you can tell what it does. All right, Brugia malayi, very much just like Wucheria with the elephantiasis kind of stuff. Again, it's got two terminal nuclei, very separated nuclei at the end of the tail is its look. So it's hard to see it, but there are separated nuclei at the very tail there. Loa loa is known as the African eyeworm, passed by a fly. It loves to go to the conjunctiva of the eye, which is why it's called an African eyeworm. Again, the nuclei do extend all the way down to the very tip of the tail on this one. So it's actually very crowded nuclei all together throughout the body of it. So that's why it looks so thick here, is that nuclei gets so crowded together in there. It's hard to see the end of that, but it's there. And then Onchocerca volvulus is another eye one. It's called river blindness, also passed by a fly. And this has no sheath to it. This is a tissue infection with it. I gotta find a better picture. Here you can see it in somebody's eye. And then on the right, it's an unsheathed look to it. Okay, oh my goodness, you guys. We have gone through all of the parasites. The last couple slides are just informational based. So the majority of what you need to know is based on those parasites. This end stuff is just, some of it's important, yes. So we're going to go through it, but definitely need to know those pictures for sure. So for fecal samples, again, because most of these were diarrhea-based parasites, we look for a lot of stool screening. So anytime somebody goes into the doctor with a history of diarrhea, a lot of times they'll order both a stool culture, because, you know, we have a lot of bacteria that cause diarrhea. So they'll order a stool culture and what they call an ONP, ova and parasite exam. Typically, they're just ordered right away together, and they'll be collected in 2 separate containers. And so with the OMP, we screen, of course, for eggs, parasites, that kind of thing. And then the stool culture, we know we obviously plate it, look for our main pathogens, that kind of thing. So with stool samples, fresh stool in a wide mouth container, want it examined within 30 to 60 minutes. Typically, we want several samples. 3 specimens throughout a 10-day period of time is ideal because that will give it more probability on finding a parasite if it is there. All right, so we can preserve that fecal sample if we cannot look at it within the 30 to 60 minute window of time. A lot of times those containers that they hand out for the patient to collect stool cultures and OMPs already have preservative based in it, so that it doesn't matter if they don't return it right away, like within an hour, we can still, it's good to go, it's preserved for later on. So here's all different preservatives that are used. Do not need to know these at all. There's just FYI on this chart. All right, as far as macroscopic examination, when you get the stool in for parasites, you obviously look in the stool. Does there have worms sitting in it? Is the consistency of the stool liquid, soft, or formed? It will make a difference on the consistency. I mean, if it's diarrhea, it should be pretty liquidy or soft, but sometimes you get a formed one. So examine liquid or soft pretty quickly. Formed stool, 2 to 3 hours. Color, brown, of course, we know is a normal fecal color. Black, if there's a black stool, typically indicates they have blood in their stool. If it's red, it can even show some fresh red blood, and of course, mucus. I love somebody actually has done this study. They have found that based on the consistency of the stool, whether it's liquid, soft, or formed, what you might find there more. So if it's a liquidy stool, you're going to find higher numbers of trophozoites. If it's a more formed stool, you're going to find higher numbers of cysts. It's just FYI. I just personally think it's amazing that somebody did that study. So, all right. Now, microscopically, of course, there's different types of microscopic preparations that we can do. We can have direct wet mounts. You can have concentrates. You can have stain smears. So in a direct mount, wet mount, you are basically taking a small amount of fecal matter and mixing with saline or iodine solution, putting on a slide, putting a cover slip over, and you are going to look at it under the microscope. So you're kind of looking for trophozoites, if they're moving, motility. Saline will preserve the motility, whereas iodine will destroy that motility. But you look for your parasites, essentially. You're going to start with low power, and then if you think you see something, you move to high power to identify it. If you decide to stain it, there's a couple different stains. We have a hematoxylin stain, a trichrome stain. These are just informational for you if you want. And of course, you saw that we acid fast stain a few of them. So again, you look at it just like you would anything else that's stained on a microscope. Malaria and babesia, a lot of times we see with right hematology stain because they're inside the red cells. So there is thick preparations and thin preparation smears. Thick is just to scan for parasites in general, and then the thin is used to identify the actual parasite. All right, so that is finally it. So we will definitely go through pictures. I will have a picture PowerPoint that I'll hand out or upload into the shell after we're done going through them so that you can practice these pictures on your own and get to know them for the test. Have a great week, and we'll see you soon.